This is part 3 of Unit 11, Neonatal and Obstetrical Transfusion Practice. This part will focus on the laboratory investigation during the neonatal period. A sample of cord blood is obtained from every infant at the time of birth, and you want to avoid contamination with Wharton's jelly. Wharton's jelly is a gelatinous substance which protects the umbilical cord. If it contaminates the cord blood sample that is collected, it will coat the cells and cause false positives in the forward type because it is protein. It is sticky. So these cells, if you just put a drop in a test tube and spin it down, that drop of blood will appear to be agglutinated. If a false positive is obtained, wash thoroughly and repeat the test. So for a while, we were getting samples. The nurses collect this in the delivery room. The umbilical cord is snipped, and then they would milk it into the tube. And by milk, I mean they would grasp it and then apply pressure and squeeze the blood into the tube. Well, during this process, Wharton's jelly would also be collected. We're going to discuss laboratory investigation during the neonatal period, and the neonatal period is the time period surrounding the birth of the baby. A sample of cord blood is obtained from every newborn, and the prime objective is to avoid contamination with Wharton's jelly. Wharton's jelly is a gelatinous substance which protects the umbilical cord. If it contaminates the cord blood sample, the cells will be coated, which will cause a false positive in the forward type of the infant. And since we can only do a forward type on the infant, why can't we do a reverse type? Because those antibodies would come from the mom, number one, and we need IgM antibodies, which the baby cannot produce. So again, we rely on the forward type only. So if the cells are coated with Wharton's jelly, then you would get a baby that would type, forward type is AB pos. You would run your control, your negative control, and it would also be positive. How does this happen? Well, in the past, the nurses collect this in the delivery room. The cord is snipped, and they would milk the blood into a tube. And by pressing and squeezing, not only are they squeezing the cord blood into the tube, but Wharton's jelly. And so this will cause problems. And oh my God, those tubes were just coated with blood on the outside. And when I put my applicator sticks in, it looked like egg white was in these samples that were grossly contaminated with Wharton's jelly. If a false positive obtained, the Wharton's jelly is water soluble. So what you would do, what I did was I labeled my tubes for my forward type. I put a drop in each tube and I washed that 3 times. And then I added my anti-A, anti-B, and so on. And so this is a problem that's easily resolved. How you know it's occurring is because of that false positive in the forward type, your D control being positive. The tube is labeled in the delivery room with the mother's information, and this is what drives students crazy. And we have a really distinct label, and it says delivery room cord blood or words to that effect. But again, it's labeled with the mother's information. But inside that tube is baby's blood. Cord blood equals baby's blood. So the date and time of collection is also put on there, which is the baby's birthday. And if a test is not ordered on the cord blood, then it's kept in the transfusion service for 7 days. And again, I cannot stress enough, you're going to get a sample labeled with mother's information, but in that tube is baby's blood. So there is antepartum and postpartum testing on the mother. When a person finds out they're pregnant, they will have an ABO D type done as well as an antibody screen during their first prenatal visit. Then that test is repeated at the hospital during delivery. If the screen is positive, then you will identify the alloantibodies. determine their clinical significance because the clinically significant antibody is IgG. So it can cross the placenta and it can cause harm to the baby's red cells if they possess the antigen. So any alloantibody that's identified, you determine the clinical significance and notify the physician. If it is significant in the antepartum visit, then you follow with titers during the pregnancy. Because what is a clinically significant rise in titer? Fourfold. Fourfold rise in titer means this infant or this fetus possesses the antigen to which the mother is making the antibody. So the cord blood has been submitted to the transfusion service. What do you do with it? Well, you're going to determine the ABOD type if it's indicated. Some hospitals perform ABOD on cord bloods of all Group O mothers. If the baby's an A or a B, then a direct antiglobulin test is done. All cord bloods from D negative mothers must be typed. If the baby is D positive, then the mother must receive a product called Rh immune globulin, which we will discuss further on in this lecture series. You may get a false negative with anti-D on the cord blood when a mother has immune anti-D and the baby is positive. This is called the block D phenomenon. Put a star by this. I want you to memorize this. And this is due to every D antigen site on the baby's red cells getting coated with maternal anti-D. I want to say that one more time. Every D positive antigen on the baby's red cells are coated with the maternal immune anti-D because that baby has been cooking in the mom for 9 months, or probably going to be less if it's significantly affected. But during that time, the mother's producing antibody. Where's that antibody going? Onto the baby's red cells. So it gets to a point where every site is coated. So when you add your reagent anti-D, there's no place for the anti-D to attach to. So the baby appears to be D negative. The weak D test and the D control, because you take it on, you go ahead and do the incubation because they appear negative. When you get to the end and you wash 3 times and add anti-human globulin, it will be strongly positive. It's going to be 4+. It's probably going to be 1,000,000+. I've had cases where the agglutination was so strong, it stuck to the bottom of the cell and I couldn't get it off. And by the time I did, I was looking at a 2+. But I knew, initially, because I couldn't get it off the bottom, it was greater than 4+. So again, the antibody class coating the baby's cells is IgG. Your anti-human globulin serum detects IgG antibodies. It doesn't matter what specificity, it just detects IgG. And because these cells are so heavily coated with immune anti-D, then of course the anti-human globulin phase of testing will be positive, which having a positive D control invalidates the test. Some hospitals perform DATs on all cord bloods. Others will perform only if necessary. And the 2 situations is if the mom has a clinically significant immune antibody or if a Group O mother has an A or B baby. Immune antibodies can cause strongly positive DATs if the infant is antigen positive. Again, during that 9-month incubation in the mom, these antibodies have plenty of time to coat those antigens to which they are directed. Coating with ABO antibodies results in a very weak positive DAT. So I want you to know this. ABO, very weakly positive DAT, 1+ or less. It's usually, you can see it macroscopically, but sometimes you can only see it microscopically. And this is why I don't encourage giving up the microscopic reading of the DAT on cord bloods because most of the ABO HDFN DATs will be microscopically positive. Every now and then you'll see one that's 1+ or 2+, but I've never seen an ABO that goes above 2+. On the other hand, for immune antibodies, they're usually 3 to 4+. If you recall from a previous lecture, elution is the process of removing antibodies from the surface of red blood cells. These are rarely performed anymore, taking all the fun out of blood bank because elutions are really, really cool. If a mom is Group O with a negative antibody screen and the baby is an A or a B, we add the comment positive DAT probably due to maternal ABO antibodies. It takes about an hour to do a Louis freeze elution, but it's so cool because you do this elution, then you test, and the antibodies that you pop off the cells are the mom's antibodies. The antigens that we're popping them from are the baby's. And so you get these antibodies free in solution. You test them against A, B, and screen cells. And if a baby's an A, you expect the A cells to be positive, and B cells to be positive. Anti-A, B will cause a positive reaction with the other cell, but it'll be weaker. So let's say you have an A baby. Your elution will have a 3+ with the A cells and a 1+ with the B cells. And the reaction with the B cells is due to anti-A, B. So what they determined, and why we're not really doing these anymore, as it is possible to elute immune anti-A, B, or A, B off any ABO incompatible baby, regardless of the results of the DAT. And I have no explanation why this is a lighter coating with ABO antibodies versus an immune antibody, because these are IgG class antibodies. Immune antibodies, the elution is usually performed to confirm the specificity of the antibody. So let's say that you have a mom with anti-cal and the baby's DAT is positive. Then performing an elution and identifying the anti-cal coating that baby's cells is one additional piece of information that this is causing the hemolytic disease. So HDFN caused by ABO incompatibility is clinically mild, meaning the baby may show signs and symptoms or not. Jaundice most frequently developing within 24 hours of birth. So the baby is not born jaundice, because in utero the mom's taking care of the bilirubin, but once the baby's born, and due to that lack of that enzyme, the bilirubin will rise. Regarding laboratory diagnosis of ABO HDFN, I want you to memorize, put this on an index card, whatever you need to do. So we do a type-in screen on the mom. The mom is Group O and the antibody screen is negative. You perform a direct antiglobulin test on the cord cells. It's weakly positive, usually 1+ or less. You do an ABOD type on the cord cells, which those are the baby cells, and the type is an A or a B. If you were to perform elution testing on the cord cells, anti-A or B as well as A, B will be eluted. The bilirubin on the infant will be 12 milligrams per deciliter or more. Normal bilirubin in infants is less than 5.2 milligrams per deciliter. Infants are born and have higher bilis than adults as their normal values, just because it takes them a little bit of time to get their liver up and running. Bilirubin monitoring in HDFN is crucial, and there are several technologies that have been developed that avoid blood tests. The first is transcutaneous monitoring, transcutaneous bilirubinometry screening tool for jaundice in full-term babies, as well as monitoring babies with hyperbilirubinemia. If it's elevated, a blood test will be ordered. So it's kind of similar to a temperature gauge, except it's not. It's actually measuring the yellowness of the baby's skin, and that's caused by bilirubin being deposited in the tissues. This leads to an approximately 50% decrease in blood testing in the full-term infants, and a method to monitor babies who do have increased bilirubin. As I was researching this topic, I came across an article about wearable bilirubin monitoring devices, and this was published March 4, 2021, and researchers in Japan have developed the first wearable device to precisely and continuously monitor bilirubin. This is huge because the only way to truly get an accurate bilirubin level is by doing a skin puncture. And I had 2 children who developed jaundice. Their bilirubins were very, very high, especially 2 days after birth. My son was 20, which is almost exchange transfusion time. And how they monitor the bilirubin is taking a blood sample. My children had scars on their heels. I think they're probably still detectable today due to all the skin punctures they had to have done to determine whether the therapy was working. So this is huge. We don't have to have hamburger heels anymore if this device becomes widespread use. Also, it measures the blood oxygen saturation levels and pulse rate. And you can either have the app tied to a phone, or there's an actual device that you can measure, a handheld device. So 2 different ways. So the physician can have this device on their phone, and it will send the signals as to the baby's bilirubin levels. So for ABO-HDFN, the profile of laboratory testing, the hemoglobin and hematocrit on the infant are decreased because anything coated with antibody is recognized as foreign by the body and will be destroyed. On the peripheral smear, you'll have hypochromia, polychromasia, nucleated red blood cells, and microspherocytosis. The reticulocyte count on the infant is increased. And I'm not saying what these terms mean because you need to bring your hematology back to the front of your brain. Treatment of ABO-HDFN, except in extremely rare cases of severe HDFN produced by ABO incompatibility, phototherapy with UV light is the usual treatment. UV light converts bilirubin into a non-toxic isomer called photobilirubin, which is transported to the liver. And the photobilirubin is rapidly excreted in the form of bile. And one story I keep getting angry about, even to this day, it was a Friday. The baby had been identified as having ABO-HDFN. The bilirubin was rising. Usually an exchange transfusion is not done until the bilirubin exceeds 20 milligrams per deciliter. This baby's was like at 15 or 16. The doctor wanted to go out of town for the weekend, so he went ahead and did an exchange transfusion on this baby. And exchange transfusions are not without risk. So again, to this day, I'm still angry about that situation. Phototherapy or light therapy is used to treat infants whose bilirubin is elevated. And there's 2 different ways to do it. In the isolette, and this is my son, had to be, because we didn't have additional technologies, he was in an isolette with the UV lights. And it uses blue light, 420 to 470 nanometers, that converts the bilirubin so it can be excreted in the urine and feces. You have to put blinders to protect the baby's eyes from damage that may lead to retinopathy. So they glued little patches to my son's face on either side, Velcro, and then we put the little blinders on him. And they used a face mask as a diaper. They removed the little piece of metal because they wanted as much exposure of the skin to this UV light as possible, because the more exposure, the more bilirubin would be broken down. And they say usually do not wear a diaper. Well, yeah, you kind of want something down there. And this can be done at home. My second child, who I knew was going to have the same issue, we were able to take her home, and we had home health come, and they put this the isolette on top of my dresser, and we put my baby in the box. And I laughed because my family would come over and want to see the baby, and here she is on my dresser on display. But it was so much more humane than being in the hospital. and so much safer for the baby because you don't want newborns exposed to people. And we could not take her out of the isolate. I could take her out to feed her, but otherwise I had to leave her in the box. The newest form of phototherapy continues to be the Billy blanket, and this is much more humane. It's a lightweight fiber optic pad that delivers up to 45 microwatts of therapeutic light for treatment of jaundice, and this allows the infant to be swaddled, be held, be cared for by the parents and hospital staff. The compact unit can be used for hospital and home care. I like this picture because it illustrates bilirubin degradation by phototherapy. So you have the light, you have the bilirubin, and then you see the breakdown of bilirubin by this light into different components at the skin level. These components then go into the blood, they go to the liver, some of them go to the kidney, then in the liver they are then processed into the bile, which is processed into the intestine. And oh my goodness, the stools are just so gross and nasty. They're a really dark green. If any of you have been around newborn stools are usually a very pale tan or a darker tan. But yeah, these were not nice to look. As I said before, the need for exchange transfusion is rare, and I can count on the fingers of one hand that I've had an ABO-HDFN that required an exchange transfusion. There is a risk of mistake being made and giving baby their own A or B type, which will trigger more hemolysis. What you must remember is this baby is two people in one. The antigens are the baby's, the antibodies come from the mom. So this is why when we're setting up blood for an exchange transfusion, the blood must be compatible with the baby and the mother. This will eliminate any errors that may occur that you mistakenly select a Group A unit for this Group A baby when in fact that can't be done. So we're going to cross-match the donor both with the mother and the baby. And it has to be D compatible with the infant, meaning if the baby's D pos, we give D pos, D neg, we give D neg. So you have a Group O positive mother, the antibody screen is negative, and the baby is negative. So again, we've already done the DAT, we've done the bilirubins, this baby needs an exchange transfusion. State the donor ABO D type for the baby. So if you said O negative, you are correct. Group O is the only blood that is compatible with both an O and an A person. And because the baby is D negative, the baby must get D negative blood. So again, O negative. Other hemolytic disease is very uncommon, occurs in approximately 0.8% of pregnant women. Immune alloantibodies are usually due to anti-Big E, little c, Cal, Kid, or Duffy. Anti-Cal is the one that we are most concerned with, and the disease ranges from mild to severe. Over half of the cases are caused by multiple blood transfusions to the mother. So she was exposed due to a transfusion to produce this antibody. It's the second most common form of severe HDFN, and I want you to know that. Anti-M is one of the unicorns, is very, very, very rare. It has been documented in the literature, but I don't want you to think about that when we think about other hemolytic disease, because these other antibodies are more common. So if you're making an index card, I would recommend you putting this on as the profile for other HDFN. When you do the type-in screen on the mom, the antibody screen is positive. You will perform a panel and an immune antibody will be identified. For the DAT on the cord, it will be positive and the strength will vary. The elution testing on cord cells, you want to remove the maternal antibody from the baby's cells and test that eluate against a panel. And the specificity of the antibody should be the same as the maternal antibody, unless you messed up. If the baby is also ABO incompatible, then you're going to throw an A and a B cell in there as well. So you'll have the 11 panel cells plus an A cell and a B cell, to where, again, it can be ABO and other. I guarantee you ABO will be involved if the baby's ABO incompatible with the mom. The bilirubin is determined and evaluated, and a CBC and reticulocyte count is determined and evaluated. HDFN may be diagnosed prenatally if this baby contains the antigen to which the mother has an antibody. So when you do a prenatal screen, the antibody screen will be positive, and depending upon the antigen strength on the baby's cells and other variables, the other HDFN disease ranges from mild to severe. Most can be successfully treated with phototherapy. Treatment of other HDFN, this may be diagnosed prenatally. If this is an immune antibody stimulated due to a previous pregnancy or transfusion, then our antibody screen would be positive, and you would want to identify the antibody and monitor the fetus. Depending upon the strength of the antigen on the baby cells and other variables, the disease ranges from mild to severe. Most cases require phototherapy for successful treatment of the disease. Rarely an exchange transfusion is necessary. The donor blood must be compatible with the baby and the mother. The donor blood must lack all antigens to which she has antibodies. So you have a group O pos mother with anti-Big E. The baby's B positive, the DAT is positive, 4+. What antibodies do you expect to elute? Pause the presentation. You will expect anti-B, anti-A, B, and anti-Big E to be eluted from that baby's cells. What is the ABOD type for transfusion? If you said O positive, you're absolutely correct. The only donor blood compatible with the Group O mom and the Group B baby is Group O. What additional antigen must the donor unit be tested for and the expected result? It must be tested for the Big E antigen, and it must be negative. The last type of hemolytic disease we're going to talk about is RH, or anti-D hemolytic disease. Early 1930s classic observation of kernicterus, hydrops fetalis, and anemia were termed erythroblastosis fetalis. In 1938, it was suggested that the cause was the transfer of immune antibodies, incorrectly assumed that fetal hemoglobin was the target. With the discovery of the D antigen, this led researchers to correctly identify the issue. Immunization to the D antigen depends on the dose of D positive red cells given and the ability to respond to the antigen. 1/3 of individuals are non-responders. We had a patient who needed platelets from family members because she was refractory. She was D negative. She had 4 D positive children. She was a non-responder. There are 2 types of responders, and this differs in the terms of type and quantity of anti-D. Hyper responders produce extremely high titers of both IgM and IgG anti-D forever. I've only seen a few of these. At immediate spin, your screen is positive. It stays positive at 37, and it's positive at Coombs. So this would be termed a hyper responder. Immunization to the D antigen is caused by exposure to D positive red cells either through transfusion or pregnancy with a D positive fetus. Or, like I said before, you can have these bizarre situations, the little girls becoming blood brothers with each other, And yeah, she got pregnant and had immune anti-D identified, and that was due to this previous exposure. They say as little as 0.1 mLs of red cells can cause immunization to the D antigen. Subsequent exposures, such as pregnancy with the D positive fetus, will elicit that secondary immune response, so you get this bounce in titer that's incredibly fast due to re-exposure. And of course, it's a secondary immune response, and the antibody class is IgG, which can cross the placenta. So this picture illustrates how the male must be D positive, and so she's pregnant with the D positive. The fetal red cells can enter her bloodstream, and if she is a responder, she will become sensitized or immunized to the D antigen on these Rh positive cells. And of course, in a subsequent pregnancy, the results are devastating because it is a secondary immune response. If the current pregnancy is the immunizing event, there's seldom clinical signs of HDFN. It's a primary immune response, which usually takes weeks to months to develop, and the antibody first produces IgM. If the antibody progresses to IgG, the DAT will be positive. But in a primary immune response, usually the antibody titer is not high enough to cause severe hemolysis. If this is the first pregnancy and HDFN is severe, there must have been a previous exposure. The maternal IgG anti-D rapidly destroys fetal D positive red cells, which results in anemia. And anemia limits the ability of blood to carry oxygen to the baby's organs and tissues. The baby's response to hemolysis is trying to make more red blood cells very quickly in the bone marrow and the liver and spleen. So the organs enlarge, we have hepatosplenomegaly. New red cells are released prematurely from the bone marrow and are unable to do the work of a mature red blood cell. As the red cells break down, bilirubin is formed. Babies are unable to get rid of massive amounts of bilirubin. In utero, the mom can take care of some of it, but it comes to a point that even that doesn't work and the bilirubin levels are very high. They build up. The term used is hyperbilirubinemia, and other tissues and fluids of the body, baby's body, result in jaundice. The placenta helps get rid of some of the bilirubin, but not all. Prenatal diagnosis of anti-D, detectable antibody titer rarely observed before 28 weeks if this is the immunizing event. It's usually detectable at the 35th week or later. Remember, full-term pregnancy is 40 weeks, and the titers are low. In subsequent pregnancies with a D-positive fetus, I want you to know this, an anti-D titer of 16 or higher with a previously affected child, or 64 or higher without history, indicates an affected fetus. In these cases, amniocentesis should be performed at 24 to 28 weeks or 6 to 8 weeks prior to the previous fetal loss to assess fetal status. Again, this is a very pathogenic antibody that can result in stillbirth if not caught early. Complications of the fetus during pregnancy: severe anemia with enlargement of the liver and spleen. When these organs and the bone marrow cannot compensate for the fast destruction of red blood cells, severe anemia results and other organs are affected. Hydrops fetalis. This occurs as the baby's organs are unable to handle the anemia. The heart begins to fail and large amounts of fluid build up in the baby's tissues and organs. A fetus with hydrops is at great risk of being stillborn. This illustrates a severe case of hydrops fetalis. Clinical presentation varies from mild jaundice and anemia to hydrops fetalis with ascites, pleural, and pericardial effusions. The chief risk to the fetus is anemia. Extramedullary hematopoiesis due to anemia results in hepatosplenomegaly, that's where more blood-forming tissue will produce more cells to combat the anemia. The risks during labor and delivery include asphyxia and splenic rupture. As the spleen enlarges, it becomes friable, fragile, and can rupture. Clinical presentations postnatally means after birth: asphyxia, pulmonary hypertension, pallor due to the anemia, edema due to hydrops and low serum albumin, respiratory distress, breathing issues. Coagulopathies include decreased platelets and clotting factors, jaundice, kernicterus. Remember, kernicterus was where the bilirubin will coat the brain. And then hypoglycemia due to hyperinsulinemia from islet cell hyperplasia. For the mother, a type-in screen will reveal the positive antibody screen. Anti-D is the most common form of severe HDFN, with the disease ranging from mild to severe. In addition to anti-D, we may also have anti-big C or anti-big E. For the infant, varies with the severity of HDFN, anemia, hyperbilirubinemia, reticulocytosis, increased nucleated RBCs, thrombocytopenia, leukopenia, positive DAT, hypoalbuminemia, and on the peripheral smear you'll see polychromasia, anisocytosis, but no spherocytes. So look at this peripheral smear. So you can see polychromasia, anisocytosis. You can see numerous NRBCs because, again, the anemia is so severe that they're putting out the red cells before they're ready, but there's no spherocytes. So the white arrows show you the polychromatic red cells, meaning they have that bluish color, and then the red arrows indicate the nucleated RBCs. So again, this is a peripheral smear of infant with severe HDFN. This is the end of Unit 11, Part 3.